Welcome everyone to today's webinar. I'm Julie Spitzer, a reporter with Becker's Hospital Review. We will begin today's webinar with a presentation, and we'll have some time in the middle and at the end of the hour for question and answer sessions. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, it is my pleasure to turn the floor over to Jennifer McGuire, Senior Account Director of Health System Solutions at American Well, to begin today's presentation.
Great. Thank you so much, Julie. And first off, a big thank you to Becker's for hosting this session and everyone for joining us today. I can tell from how many folks have signed up and joined us online that this is a very timely topic in the world of telehealth. So very happy to have everyone today, including the Intermountain team. My name is Jennifer McGuire. I'm an account director here at American Well that has the pleasure of working with many of our health system partners and specifically with the Intermountain team that will be presenting today. And before we introduce our presenters, I just wanted to provide a quick overview of American Well for those of you that might not be as familiar. So the company was founded by industry veterans, Drs. Ito and Roy Schoenberg, and has been a leader in the telehealth space for a little over a decade, with a mission to always bring quality care anytime and anywhere a patient may be. And through those years of research and dev, we have created and operate one of the largest video telehealth technologies in the country that includes mobile, web, kiosk, and cart solutions. So ultimately, we are bringing that technology to our ecosystem of partners to increase access to care in an affordable and transparent way that eliminates distance, time, and mobility barriers to consumers. We have a saying here that our clients run American Well, and that's very true. We truly partner with our clients to help bring their visions and unique telehealth use cases, looking at over 140 specific use cases to date, bringing those to life across all key verticals, including health systems, health plans, and employers. Next slide. So onto the Intermountain system. Many of you may be familiar with this very recognized leader based in Salt Lake City, Utah. They have been well known for their clinical quality and efficient and innovative care delivery models over the years. They are an integrated system of more than 23 acute care hospitals, over 180 clinics, large medical group, and also with their own health plan, Select Health. Next slide. So they've actually launched their urgent care telehealth service back in 2016 with American Well. It is branded as Connect Care with the goal of increasing convenience and access to services while also reducing costs and retaining their patient base. Since launching initially with employees and health plan members, they have since grown their urgent care service throughout the state and also installed kiosks as another front door to the Connect Care service at employer sites and recently at a South Salt Lake Community Center. With their leadership and attention to clinical and operational detail, they really have grown this program exponentially over the last couple of years. Next slide. So without further ado, here to tell us more about their program and specifically about the virtual visit claim study is Tim Lovell, who is our operations manager for the Connect Care service, Dr. Joe Dalto, who is the senior manager for the telehealth team, and last but not least, Dr. Jordan Albritton, who is a statistical data analyst and statistician behind the methodology for the study. So without further ado, I will turn things over to Tim to get us started.
Fantastic, thanks, and a great pleasure to be sharing this information with you today. We've been very excited about the work that's being done and happy to have this venue to share it and also just to promote telehealth where it's applicable in improving access to care around our country and with other health systems that are working toward that aim. So we'll cover two main topics today. First off, we'll go over the virtual visit claim study that we've been working on. And then later we'll go through a model for defining virtual visit care, and we'll pause for questions after each of these different sections that we go through. There's a number of people who've been involved in this project that aren't on this call, but we just wanted to acknowledge them: our medical director, project coordination, and a lot of the claims analysis and providing of that. And so this has been a joint effort by a lot of different individuals to kind of bring all this work to bear, and would be amiss if we didn't give credit to this large group of people that has been helping us. So just to start off, we want to talk, get a little bit more detail about Intermountain Healthcare as the context for the study that we did, and Jen did a great introduction on kind of where we're coming from. We have a model to be or a vision to be the model health system, and focus on how we can have value and how we can deliver the best care at the best price for our patient base. In addition to kind of the hospitals and clinics mentioned, we operate 35 urgent care or Instacare clinics across our service area, and so we deliver care in all of these different mediums, in ED and primary care, and ED, and now in virtual care as well. We're very closely partnered with our own integrated health plan, Select Health, which is at 850,000 members across the service area, and that includes commercial plans, individual plans, and both Medicare and Medicaid plans that are part of that. So we're going to kick it off with the claims value study and talk a little bit about, we'll start off with just how this study was designed, and for that I'm going to turn some time over to Jordan to take us through this.
Great. So, of course, we believe that using virtual visits for certain minor conditions, urgent conditions, offers a value for patients and payers, as well as healthcare systems. And although we're already providing the service, we wanted to do a deeper dive to help us demonstrate that value. So we started by looking at the literature. It's always a good place to look. And there really isn't a lot of evidence on the value of online urgent care visits. Existing research actually shows mixed results on the impact to the overall cost of care. And some have suggested that virtual visits could simply add another step in the care process, which is really the last thing we want, is a situation where virtual care becomes sort of a gate that patients have to pass through before they enter a brick and mortar facility. Despite these concerns and mixed evidence, we still believe that virtual care can be implemented to increase access and reduce costs, at least, again, for certain minor urgent conditions. And then we think that's what we're doing. There was a study published in 2017 by Gordon et al. That actually provides some support for this hypothesis. They did a claims analysis from the perspective of a commercial insurer and showed that virtual urgent care can be a cheaper alternative. And we wanted to see if those results held within an integrated delivery system with its own insurer like Intermountain. So we conducted a similar study. The main objective of this study was to compare costs for minor urgent conditions based on care setting. We used claims data again from Select Health, our insurer, for the analysis. We looked at episode of care, which we defined as an index visit with all claims within a 21-day period. And by definition, index visits are visits where there was no claim for a visit within the previous 21 days. In addition to cost, we had two other key outcomes. So we looked at the total cost of the episode, which again included all visits, prescriptions, labs, and imaging for that 21-day period. We also looked at follow-up rates in various care settings and utilization rates for labs, imaging, and antibiotics. We used generalized linear models for the analysis. For the cost analysis, we used gamma distribution and a log link. And for follow-up and utilization rates, we used a binomial distribution with a logit link. The results were used to project cost, follow-up, and utilization based on that virtual care distribution of patients and their characteristics. And then we also used responses from patient surveys from the virtual care setting to project savings or added costs. So again, we obtained a claims data set for index visits in virtual care, urgent care, primary care, and the emergency department. We included 10 diagnoses of interest, so like minor conditions such as sinus infection, conjunctivitis. And to reduce concern about differences in comorbidities, we excluded patients with a Deo Charleston score greater than 2, and we limited the analysis to patients under the age of 65. 1,531 virtual care visits from April 1st, 2016 to March 31st, 2017 met the inclusion criteria. And for every virtual care patient, or rather every virtual care case, we included up to 3 patients that showed up in primary care, 3 in urgent care, and 3 in the emergency department. Of course, we do expect some differences between patients that use virtual care and patients that show up in other settings. So we matched the other care settings based on that virtual care population. So patients were matched on age, whether they were adult or pediatric patients, primary diagnosis, and a limited set of comorbidities. Ultimately, we ended up with just under 4,400 urgent care cases, almost 4,400 primary care cases, and 2,285 emergency department cases. So before we get into the results, it is important to note that there are some limitations for this study. So first, the results could be different for patients that didn't meet our inclusion criteria. So patients that had more comorbidities or other primary diagnosis codes than what we looked at. And second, we only had data on SelectHealth patients, which is about 50% of our patient mix in Connect Care. So we don't know if the findings would hold for patients with other types of insurance, but from our experience, we believe they do. Third, we're unable to complete the 3-to-1 match for emergency department. And this is largely because there are fewer cases of sinusitis and those other, more minor conditions that we see in virtual care, which is good. And although we did control for diagnosis and comorbidities in the analysis, it could still impact the results. And then, although the analysis focused on simpler conditions, which again are more appropriate for virtual care, we're unable to completely control for factors such as acuity and patient preferences, which could definitely have an impact on our findings. So I'm going to pass this over to Joe Dalto, and he's going to talk through the findings.
Hi, this is Joe, and I'm pleased to present the results of our study to everyone on the call. And what we found is there weren't a lot of surprises, but there were some striking differences that are noteworthy. If we just look at our sample characteristics with regard to demographic, we did have similar distributions of gender, age under 18 for pediatrics across the care settings. We had similar distributions for comorbidities with regard to diabetes, hypertension, CHF, and COPD across care settings. And for 3 of the 4 care settings, virtual care, urgent care, and primary care, we did have similar rates of those low acuity diagnoses that were appropriate for virtual care. However, in the ED, you do see some differences. You do see higher rates of URI and UTI in our sample population, and one of the primary reason being is if you remember back in our selection criteria, it was difficult to get full matching with the ED, so that accounts for some of the differences in distribution. And just from an overall population, it's not surprising that the distribution of these conditions in the ED is different than in the other settings. Looking at quality indicators, 21-day follow-up rate overall for any follow-up medical visit, virtual care, urgent care, and primary care were all about 1/3 of the visits led to a follow-up visit. No just statistical differences there. A fairly substantially higher rate of follow-up visits in the ED. Not surprising here because the ED, the relative acuity, even though we did try to balance on comorbidities and matching, the EDs also often recommend follow-up with primary care so that your primary care is aware of the visit you had in the ED and assures that that condition is resolved. Okay, not surprising there, but a difference. Looking at specific types of codes with regard to E&M, similar differences again between virtual care, urgent care, a slightly lower rate in our primary care in our study, which was significant. And then, of course, a higher rate in the ED. With regard to emergency follow-up, the rates across virtual care, urgent care, and primary care were similar. A higher rate in the ED, again, not surprising, and then inpatient, similar rates in the 3 settings with a slightly higher rate in the ED, but statistically significant. With regard to lab imaging and antibiotic use, I don't think there are any surprises here. That our lab use by design in virtual care is much less than the other settings. There just isn't available, nor do we have the capacity to do that. However, our service does provide a rapid strep. So for certain conditions that might indicate strep, we can have an order to a local lab that can be taken care of fairly quickly and then follow up with a appropriate treatment based upon the results of that lab. So there is some lab use, limited. So it's not surprising to see urgent care, primary care, and the ED have higher rates of lab use. Imaging studies, again, the same type of circumstance, that urgent care, primary care higher than shown in virtual care, and the highest being in the ED. I don't think anything surprising there. And this is important, as the antibiotic claims, 3-day claims, indicated that virtual care was similar to urgent care, primary care, and we saw a slightly less and statistically significant difference in the ED than the other settings. But we were assured that our performance with regard to antibiotic claims was similar to the other comparable settings, and gave us a sense that we aren't needing to overutilize some of the antibiotics to compensate for inability to diagnose or treat. The meat of this study was about cost analysis. Again, we won't find anything surprising here, but what we should, when we do see some striking differences, the cost of virtual care is much less than urgent care, primary care, and substantially less than the ED, by well over $1,000 with regard to the ED. Pharmacy costs, similar across virtual care, urgent care, and primary care, and but higher in the ED. Follow-up costs, lower in about almost half in virtual care compared with urgent care, primary care, and substantially lower in the ED, And then overall total cost, you can see this is where the striking differences are, and where we believe that our care that we're giving for those indicated conditions is appropriate. There's an opportunity, a pretty substantial opportunity for cost savings, particularly thousands of dollars over an ED visit, hundreds of dollars in the other compared to the other settings. Now, because of our sample size, we were unable to look at individual diagnoses of those 10 conditions. However, we just wanted to show you the relative differences in some of the top conditions: sinusitis, conjunctivitis, UTI, and URI. You can see striking difference between virtual care and the emergency department, certainly across all settings, and you can even see those differences in the primary care and urgent care differences by diagnoses. So overall, we found significantly lower cost for virtual care than the other settings. It reaffirmed the results of Gordon in 2017 for an integrated system. We found the higher total cost in the non-virtual care venues is driven by their index costs and then their follow-up costs. And the treatment of common virtual care conditions in the ED represents substantially higher costs for both the system and the patient. There's the opportunity when we built this service that we were looking to target, and we are reassured that it's reassuring that if we can grow that population or grow those volumes in population, that we can be making a difference to our patients, providing lower cost, access, and also to the system overall. With no significant difference we found in follow-up rates that might give an indication of inferior quality, or no significant difference in antibiotic claim rates. All right, that wraps up our claim study portion of it, and we'd like to open it up to the group for questions based on the study.
Thanks, Joe. This is Jen McGuire. I've got a few questions that have come in as we've been speaking. The first question is, how did you assign the cost to the virtual visit and actual urgent care visit when doing the comparison?
Yeah, those came from claims. So those are common claims codes that were taken from from our Select Health partner, and they provided those data for us. Yep. So they're a similar claim, and all they did is differentiate what setting those claims came from. Like the E&M is a common claim across all settings. Labs, they have categorical analogous categorical claims across those settings.
Great. A couple questions around the providers that you've used. So did Intermountain use their own providers for the virtual care episodes? If not, would that have altered the outcomes?
Yeah, good question. So Intermountain uses a combination of providers to service this. About 80% of those serviced were by Intermountain nurse practitioners and PAs. About 20% of that was through our partnership with American Well and the online care group. One thing, just to clarify on that as well, when Intermountain launched its service, we did specifically design our protocols to fit in, and those were reviewed by our clinical programs to ensure that we had a focus around antibiotic stewardship, around appropriate use cases. So the study in large part was to confirm that we were actually complying with those protocols that we designed.
Yeah, the concordance was also done with American Well to assure that there wasn't a difference in care if you received an American Well provider versus Intermountain. So we looked at assuring that the guidelines and protocols between American Well and Intermountain were also aligned.
Great. Thanks for that clarification, Tim. We had a question here. If I understand correctly, 73% of patients were seen within 21 days after a virtual care visit. Did the diagnosis or outcome differ after that visit, and or what percentage was the complaint the same or similar or related?
I thought the data didn't say 73%, it said 35%.
73% for the emergency.
Oh, emergency department, yes. Yeah, if that's the data of the emergency department, then there was any follow-up medical visit. And it's not, again, one of the reasons driving that is the emergency department will encourage you to go follow up with your primary care. We think that might have been a substantial one. And not only that, but the emergency department does have a difference in acuity, which may indicate they may also request that the patient follow back with them.
Yeah, but if you look at the virtual care, urgent care, and primary care, the follow-up rates were virtually, no pun intended, identical. And so it's really striking to see the results that similar.
Great. And this is sort of a foundational question, but what's the base definition of virtual care, just to level set?
Yeah, so we have in virtual care, by this, we're specifically referring to urgent care visits within a specific scope of practice that's been defined. For the purposes of Intermountain, we have that staffed as a separate set of providers, for the most part, than what are providing services for these for other programs within us. But it is no existing relationship. It is, as you think, traditional urgent care, just delivered online.
Great. Next question. Did you measure direct or indirect for cost? Is the cost to the plan or to the health system?
The cost is the claim, so it's from the insurer, and so we actually use the allowed cost. So we have the billed cost, the allowed cost, and then the paid cost. So we use the allowed cost that the insurer then passed on to the patient, and that was based on the 21-day period and included all costs. Again, a patient could have had cancer or could have had no issue, but those would have all been captured in there. And but that cost potential bias there would have been accounted for or present for everyone, regardless of whether it was virtual care or primary care or ED. So.
Great. Another question, did you look at if it mattered if the virtual care visit was conducted by, say, an ED doc versus a primary care doc or NP?
Yeah, good question. We didn't look at who was providing that service. The only comparison done on the claims was the venue in which the service or the care was provided.
But all of the virtual care visits, those are either provided by, again, American Well or our urgent care providers.
Yeah, in our system, all of our emergency care is provided by emergency physicians.
Yep.
So that happens to be our system. That's not necessarily everybody's system.
Right. So there's probably very, very little, doctors providing care in multiple settings.
Yeah, and certainly in our primary care, there's plenty of nurse practitioners that provide care.
Yeah, just going back and clarifying one thing too on the cost question. So that total cost represents both a combination of the claim or the payer portion and the patient portion of that cost.
Gotcha. Got a few more questions here. Lots of great questions. Next one is, if a patient with sinusitis had a virtual visit and then their symptoms progressed into a cough that their PMD diagnosed as bronchitis, would this be reflected as follow-up for the sinusitis condition in the study?
Yes, it would. So again, the episode was based on that primary diagnosis. So if you had a primary diagnosis of sinusitis, and then regardless of what you followed up for in the next 21 days,
claims.
all claims are going to be captured in
And we just grouped them into the different settings, whether it be lab, antibiotic, or imaging, or it was a visit. Yeah.
And even if they had a separate visit for a cough, that was 17 or 18 days later, that cough diagnosis doesn't really matter for this analysis.
It was all diagnoses, all follow-up diagnoses.
Great. And just in general, when you're referencing lower costs for virtual care, is that a lower cost for the patient or the health system, health plan, or all?
Yes.
So yeah, that's the total cost of the total allowed amount for that claim. So depending on the patient's plan, the member's plan would determine how much that total cost is paid by the patient versus the health plan.
Yep. And that's a really important point too, because a lot of times in this sort of sphere, if you innovate, you also pay for that innovation, and you don't reap the benefits. And so this is a situation where having a more capitated model where if you do save money for the patient, that actually is going to help the health system more too. So
great. Question about the possible reasons for pharmacy costs being lower for virtual care in the study. Any comments on that?
Could you repeat that question, Jen?
Sure. What were the possible reasons for pharmacy costs being lower for virtual care in the study?
Actually, if you look at the data, go back to that slide and show it on the group. They're all comparable. There was no statistical difference between virtual care, urgent care, and primary care. If you notice, you can look on your screen. It was slightly higher in the emergency department for pharmacy costs. So statistically, we saw no difference. Except in.
Do you believe? Oh, go ahead.
Yep, that's it.
Antibiotics question. Do you believe the lower antibiotics rate in the ED is due to higher level of testing in the emergency department?
That's one part for sure.
Yeah, we've talked about that with our medical director quite a bit, and he felt like it was, and of course this is just our hypothesis, but with the tools they have in the ED, they could run a CT scan and rule out a sinus infection, for example, that would be normally treated with antibiotics.
Great. I think we've got time for just a couple more here. Did you reallocate provider productivity versus regular office visits?
So we didn't look at provider productivity. We were looking simply at the claims side of things in the way that we approached the study. As far as product, part of the way in which we're just more kind of a service cost, which is kind of getting into more our second section. Our design of providing the service is relying on more nurse practitioners and PAs for providing that service, which is in part what drives the actual retail or contracted allowed rates for these different services.
Great. Did Intermountain make any operational improvement changes as a result of these findings?
Good question. So these findings are relatively recent. I think what it's highlighted is probably work that's already been underway to shift and inform kind of as much as we can, direct patients to the appropriate venue in receiving their care. So we certainly have a lot of educational and marketing efforts underway to affect that and do that, as well as kind of efforts within some of those venues. We're not controlled by law to direct and inform patients about the cost of receiving their care in those venues.
Yeah, these data help the overall system. There are people in our system that are somewhat unfamiliar, providers and services, they're somewhat unfamiliar with virtual care, and it helps reassure them that for indicated conditions that we can provide a good value and service without necessarily having an unexpected added cost. And so now the system can feel a little bit more at ease about taking advantage and utilizing it without feel like they might be compromising care of the patient.
And also, we have to justify the value of this service internally. And so in the next part of the presentation, I think was going to get a little bit more into that. Yep.
Great. Just maybe two last questions. This is a good one. Why do you think virtual users have less follow-on medical care? Is it something about the nature of the virtual visit, or are you preferentially selecting patients that would have had less medical expense regardless of the presence of a virtual visit?
Well, certainly the latter is what we want and hope. The whole purpose, by design and by purpose, is we're trying to take the low acuity conditions from settings that are expensive. In particular, the emergency department systems cannot afford to be able to pay $3,000 for conjunctivitis or sinusitis. That's unsustainable, and patients won't tolerate that. Payers certainly won't. So you want, by design, that those low, easy cases to be ideally, hopefully, in our integrated system, funneled to a setting like virtual care. Certainly, with that respect, that was by design and by intention.
Yeah, and I think if you look at the follow-up utilization, of course, we expect more, for some of the reasons that we talked about in the emergency department. And I think that does reflect higher acuity, but I think the real striking thing is when we look at the urgent care and the primary care, we see similar follow-up rates. So actually, I think that if we saw higher or if we saw lower follow-up rates in virtual care compared to the in-person urgent care or the primary care, that might be an argument that we can make that, we are getting those lower acuity patients. But I think when we see similar follow-up rates compared to those two settings where patients are perhaps most likely to show up for some of these conditions, I think that helps confirm that, there probably isn't a huge difference in acuity. And so we still see lower cost despite similar follow-up rate.
Great. And last question before we continue on with the presentation. For primary care, do you know which types of visits needed to come back within the 21-day period? You said about 35% needing to come back within the 21 days after the initial visit. Any idea on those types and conditions?
Like the individual diagnoses, like what the distribution of diagnoses for follow-up? I don't know that we looked at that specifically by diagnoses because we found that we didn't have enough samples to do the overall cost comparison, and so we wouldn't have had the same for the follow-up rates or the other types of measures.
Great. And I think we've got a few more questions, but I think we've covered quite a few of them, and want to make sure that we get to the second half of the presentation. So I'll turn things back over to you, Tim.
Great. Thank you. So just a quick recap and kind of a transition is, well, what does this mean and what are the implications for us as an integrated health system? And I think we've probably made these points already, but really they're twofold. First of all is that directing patients with these applicable conditions to virtual care can lower the overall health plan costs, both for the kind of the patient side as well as for the payer side of it, but also that it's not associated with any higher rates of antibiotic claims or follow-up care. Now, obviously, as we talked about, we designed our virtual care service to abide by protocols that would suggest that, so we almost designed our own results to this. But we wanted to make a distinction here and disassociate, and really part of our intent here is to say that the type of care presented in virtual care really depends on who's providing that care and how it's being provided. and not to say that care provided virtually is a certain way because of the fact that it's virtual care, but that can actually be designed to be such that there's no higher antibiotic claims rates. The second implication is that health plan savings should be considered as part of the overall value proposition to an integrated health system. And this is where we see huge value and opportunity for us. So how are we kind of thinking about the value of virtual visits in our integrated health system? So we talked about the claims cost reduction. That's a key part of it. We also think about the patient value, and part of our organizational structure, we're focused on what is the value we're bringing to a community as a not-for-profit. And then also, what is that system value? Those all combined create what do we think the overall value package of a virtual visit is. So we've taken some of the data from this claims study and done some extractions on it. So you can see on the left of the slide here, what you're looking at is that total claim cost per episode over that 21-day period of time. We've matched that then with a post-visit survey question that's answered by those that participated that had a virtual visit, and so they get that question. The question is asking them, what would you have done today if you hadn't had this visit in virtual care? And so just breaking down the numbers that we're looking at here, 58% would have said they would have gone to urgent care, 25% said they would have gone to their primary care provider, 4% said they would have gone to the emergency department, 11% said they would have done nothing, and then 2% said they would have used an alternative virtual care service. So if you look at those, each of those, and then match up the cost of those different care venues, add in the added cost of the done nothing, the 11%, because we need to make sure we capture that in there, then what is the total cost impact? So I think this is interesting to note. There is, if you make something more convenient, you will get more utilization from it, but we're not seeing substantially high numbers of that utilization. It's that 11%. So if we look at that and where that kind of gets us to is about $367 per claim that is the savings overall to either the payer or the patient that's involved in that. So as an example, if we look at 5,000 claims, which was close to the total count for the initial study with before the exclusions, then you get a total claims reduction in almost $1.8 million. So what does this do for us? So we're going to look first at the patient value side of things, and then we're going to look at the system value side of things. So on the patient value side of things, we did also some research to break down and look at what is the time savings, what are the travel savings, and what are the visit savings that are associated with that. As far as time savings go, it takes, our patients are on average about 7 miles from one of our urgent cares or our emergency departments. We made some assumptions about how long it would take to get there, and round trip, we're saving about half an hour of time for a patient in their travel. We're also assuming an average wait time reduction of 15 minutes. This is, of course, is going to be specific to the design of that urgent care practice. In our scenario, our average wait times are about 5 minutes, and we think that's significantly less than other care venues.
That is, virtual care wait times are 5 minutes compared to higher levels at our average for urgent care.
So if we then calculate, it's about almost 45 minutes per visit time that's being saved from that. We made some assumptions, and we looked at what the average worker in Utah is paid on an hourly basis. And we assumed that somebody was having to take time off work, possibly without pay, or having to pay a babysitter to have somebody watch kids in order to be able to have that visit conducted. And so based on that, it's not as significant, but it was a $12.20 income per visit savings for both the time and their time that was involved in it. We also looked at travel time. So this is gas and wear and tear in a car. So that average travel distance is about 14 miles. The federal reimbursement rate is how we calculated the value and came up with per visit $7.74. So I think that the time savings and the travel savings are part of it. They're not the most significant part. As you see, as we add this in, really where the highest value came in for our patients is that average patient cost, claims reduction cost of $127 per visit. So on average, the value for our patients, apologies, somehow I got There we go. So the value savings we got to is about $150 per patient. So we're going to take a look now at the patient, the integrated system value. And we really think about this as three different buckets. The first bucket is new patients. So this is what is having this kind of a service, what does that mean for providing continuity of care, and what does that mean for bringing new patients into our system? So we defined new patients as a patient not seen in the prior 18 months. So someone that hasn't seen, by seen we mean meeting with an Intermountain provider, primary care provider, or some provider. This isn't, we're a large reference lab site, so this isn't reference labs. It's not prescriptions from our pharmacies. This is meeting with a provider. So new patient is somebody that hasn't seen us for 18 months, but has returned within, after that 21-day period of time that they had a virtual care visit. This means they came back and saw another provider within Intermountain. So we define that and we look at what is the value and the revenue associated with that. That's one component of that integrated system value that we look at and we add into there. The second one is the health plan claim savings. So that's the health plan portion of that per visit claim savings cost. So as you saw earlier, we had about $127 savings on the patient side of that. Some of that is for uninsured patients, but some of that is also a significant portion of that is savings for our health plans. So that part of it plays into the mix. And then the last component is the obvious one, which is the budget contribution margin for our urgent care service, which is your revenue minus your expenses for providing that virtual care. That whole package needs to be considered when looking at the value, the integrated value. And this is taking a population health approach, obviously, versus a fee-for-service approach to it. And so it's a way in preparing how we're looking at the value and going forward and moving more aggressively into a population health market. So those going together, those add up to the total value. So Intermountain, we've seen some pretty significant value add after a couple of years of doing this through looking at it from this lens of opportunity. What we're seeing, what we estimate the value to be for our health system on a whole for 2018 is about $150 per patient that's being brought in value for each of these virtual care visits. So we see significant value in this, and looking forward, we think this is how we can position Intermountain Healthcare, and also kind of recommending that out to others, how to be positioned in addressing and lowering that cost of care by providing virtual care service for those low acuity conditions that require less intensive physical structures, that provide better load balancing of provider services, that provide also lower costs and platforms that can, and technology integration that can lower the amount of personnel support for providing that type of service. So that's kind of the holistic view. We're excited that we can be sharing this kind of review and our data with you, and look forward now to answering some of the questions around how we're thinking about this from a system model.
Great. Thanks all, Tim, Joe, and Jordan. As you can imagine, we do have a multitude of questions that have come in. We'll just start with a couple. Were you able to determine how many new patients were brought into the health system via a virtual care visit?
Yes, that's how we define the value in that new patient population. So I think we were seeing, it's kind of a moving metric, sliding metric, because you're looking at it over a year period of time, but we were seeing about 7% of our Connect Care patients coming in became sticky patients. Yep. So just a quick breakdown of some of our stats. I think where we were operating at earlier this year was about 20% repeat patients that had been, gotten sick and come in again. About 60 to 70% of our patients were existing Intermountain patients, but were first-time visitors to Connect Care, to our virtual care. And then the remainder is about 15% of those patients were patients that had come in for the first time into the system. And from that, we saw at least, it's approaching now 10% of those patients who've come back and become sticky patients. 10% of the total patients seen in virtual care.
Great. We received quite a few questions around patient satisfaction, if that was incorporated into any components of the study, and if these patients are factored into your Press Ganey scores.
Yeah, good question. Really good question. So we certainly have looked at patient satisfaction. It's not something we looked at in this study or that we tied kind of into this this analysis. We have not yet to date had Press Ganey being the survey tool for virtual care. In the time we did this, the study period, it was certainly not implemented then. So that is something that is in the process of being implemented now. But as far as doing a comparison between virtual care and in-person care, we haven't done an apples-to-apples comparison because we have slightly two different metrics. The quality analysis or the satisfaction analysis we use for the virtual care is a simple 5-star rating for the provider experience, and that's been pretty consistently about 4.85 stars on average out of 5 stars that we see.
Great. This is an interesting question. If Intermountain was not an integrated system, in other words, not sharing in cost savings, would the economics still be to Intermountain's advantage?
Yeah, that's an interesting question. That's a great industry question. I think that's the question that everybody who's not an integrated system is probably asking or evaluating and writing up a business case around it. So I think there's certainly value in it. I think the way that it would be approached would need to be quite different from the approach that we've taken with it. I certainly still think there would be value in association with that as health systems pick up more and more the risk of how they're treating patients and how they're addressing patients. So if we didn't have the health plan as part of our organization, at some point in time, I would say it would probably delay maybe our implementation of it, but it would become essential as we start. We'd probably focus first off on population health groups, ACO groups, and then expand out to the broader organization.
Yeah, with the ever increasing pressure on holding costs down and reducing the cost of healthcare, anywhere where you can save costs and give a comparable quality, adequate quality of care is going to be where the competitive advantage lies. And we're already seeing emergency departments taking advantage of and utilizing online care for triage of low acuity patients. So what they're thinking is that they can adjunct their emergency department with a model of providing a lower cost and more rapid care to the patient. And I can see other systems and providers doing that. If you can deliver a service at a lower cost, it just makes sense. And in fact, payers will demand that. Payers and patients are demanding that now. So even if you're not integrated, if it's costing you $500 to $1,000 to treat conjunctivitis and sinusitis, your days are numbered.
We still operate as fairly separate entities with our insurer and our healthcare system. And the other thing, I think that Intermountain has a pretty strong record of doing what's right for the patient. So.
Yeah, and I think the other point that I would say is we also work with other payers and supply these visits for directly for other, or contracted with a number of other payers as well, besides just our own health plan. We feel that it's providing a better service and helping them and doing that same kind of targeting cost decrease for patient populations.
Great. Question about downstream revenue. Have you attempted to calculate the downstream revenue resulting from any new patients that have come in through the virtual care service that are now in the Intermountain system?
Yes, we have, and that's what goes into that new patient value. Is we base that actually on the downstream revenue over the course of that first year. So we haven't projected out beyond that because that's about how long we've been monitoring the value of it, but it's based on actual revenue downstream.
Great. How are you able to direct patients to virtual care and away from other costlier venues in the program?
Yeah, so we spoke to this a little bit, that we haven't done a lot to date. And to begin it, I think there's been there's been an evolution of alignment between the different care venues that the virtual care is the way to go, in part why we did this study as well. What we're doing today to do this, though, is within our urgent care services, we'll be soon starting to offer patients who show up at an urgent care facility the option to have a virtual care visit actually within the physical facility in lieu of meeting with one of the providers. Part of that is load balancing and helping, deliver care to the patient faster, but part of that is just the broader kind of organizational understanding that we're wanting to provide the best care to the patient. And if we can provide them a cheaper visit and make that available to them even when they show up with one of our care facilities, we'll do that.
Yeah, so the bottom line is internal and external marketing, and on top of that is we're seeing payers actually sending out flyers and information material to their subscribers that this service is available and here's the conditions that it's appropriate for, and encouraging them to utilize that service.
And people in our area too have, feel like the recognition of Connect Care and the service that we provide has gotten really, really high.
Great. Another quick question. Was there any reduction to primary care or urgent care, your Instacare that you referenced, visit volume once you implemented virtual visits in the market?
It's almost impossible to detect because the volume of our urgent care is just growing new, and it's so small. It's about the virtual care. The volume of virtual care is like one small Instacare right now. It's growing, and it will have an impact. But right now, if you spread out the number of visits to our virtual care across our system, because its scope of virtual care is our entire system, you wouldn't be able to detect, a handful of patients that it might affect in any given setting.
And some of those declines, if there is a decline in volumes, can actually be perceived as a good thing, because again, it's freeing up those facilities for urgent care and the emergency department in particular for those more higher acuity cases, so that the providers there can get to those patients that really, really need that.
Yeah, I think it's going to be a function of, as Joe mentioned, the growth is going to be slow enough that's not going to make any major impact to begin with. I think what we will start seeing is evaluation, though, of that as that growth continues, and as we start to get into double-digit percent of the overall volumes of seeing those kind of conditions, that's where you'll start to see it make some adjustment in planning for those different facilities. I will say that Utah is a high growth market just from a population standpoint. So the challenge more that exists in Utah is actually growing to meet the growing population that we have.
Great. We'll take two final questions. Going back to the post-visit survey, what results were determined from the done nothing answer? Is that considered a negative, such as done nothing, so the issue cleared up on its own, therefore it did not cost the health system anything, or is it the exact opposite?
No, so we deducted that value of the savings from the done nothing, so we had that as added waste, essentially, if you think of it that way, into the value savings. So that was calculated into that total value savings. So what we would do with that done nothing category is continue to refine our marketing around when patients should use this service and when they shouldn't use this service, and make sure we're focused on things that that aren't going to just resolve themselves within that, within a certain amount of time, but to focus on those that actually need to be seen.
Great. And as just sort of a final question to wrap everything up, if some of our listeners and other health systems are looking to mimic a similar study, how would you recommend they get started and approach this type of endeavor?
Yeah, great question. So we're working on, we have the results of the study that we're working on getting published. What I would point to, and we'll put a plug in for our friends over at Anthem and look at that Gordon study. We mirrored a lot of our research and our study methods off of what they had done, and that was a health plan-based study, but that's, I think, where I would recommend getting started.
Yeah, that's exactly how we did it. We were intrigued by their results. How do we do it? We read their articles and attended their presentations. We talked to the author, Lisa Gordon, talked to her several times and emailed her a bunch of times. And now you have 2 studies that you can communicate with to try and see if you can get the similar results, hopefully get the similar results.
And we did make some modifications, controlling for a couple more factors, but so I would definitely recommend that, whatever seems relevant to you and to your setting, you should definitely incorporate those factors. But the bottom line is that you're going to need a rich data source of claims for a significant population.
That is all that we have time for.
Go ahead, Julie.
Thank you. I want to thank all our presenters for their excellent presentation and to our audience for participating today. Enjoy the rest of your day, and we look forward to having you join us for future webinars.